Baik, selamat pagi Bapak Ibu. Apakah bisa mendengar suara dari Myanmar? Seperti tidak mendengar ya.
Boleh foto monitor. Kami sepertinya belum mendengar suara dari sana.
Saya pikir sudah ya, Pak Pak Seko ya. Biasanya settingannya mau coba saya chatting sekali lagi.
Baik. Oke.
Ya, sekarang apakah bisa mendengar?
Registration 200 more 200.
Yes, sir.
Sorry.
Wait for a minute. Let me check.
Apakah terdengar, Pak Seko? Belum ya? Oh, sudah bisa mendengar ya. Terima kasih. Pak Angga Saliro bisa mendengar. Bukan, dari Myanmar. Sambungan langsung dari Myanmar, apakah terdengar oleh Bapak Ibu? Untuk CPD ke-17 ini kita pakai, oh yes, terputus-putus. Baik, Pak Irfan. Kita pakai teknologi yang berbeda, jadi dari Myanmar pun bisa melihat Indonesia, Indonesia pun bisa melihat Myanmar seperti yang ada di layar.
October is to be hosted by SSR, and November is for Cambodia.
Bisa mendengar Myanmar, Bapak Ibu?
Then
Sangat jelas.
December
bisa,
is
ya?
for the World Congress.
Baik, terima kasih. Terima kasih, Pak.
Kita
akan pembukaan dahulu, Pak Sekum,
we wait
dengan memperdengarkan lagu Indonesia Raya dan Mars Pari.
India.
Okay, so I will not post an announcement
internal untuk membahas next CPD. Kita akan sela untuk memperdengarkan lagu Indonesia Raya dan Mars Pari. Mohon izin, Bapak Sekum.
Silakan dilanjut oleh kasih.
BG, you know Christina from England.
Christina from
England. She had Mr. Christina, Professor Christina. She very well AI for student. My idea, I want to invite her. She have one lecture.
Baik, demikian tadi lagu Indonesia Raya dan Mars Pari. Selanjutnya saya akan panggil Ketua Bidang Hubungan Internasional PP Pari, Bapak Gatot Santosa. Apakah sudah gabung bersama kita? Oh, sepertinya belum. Baik, begitu beliau tergabung, kita akan mohon laporan dan sambutan dari Ketua Bidang Hubungan Internasional. Dan pagi hari ini juga kita dihadir oleh Bapak Sekum PP Pari. Bapak Sekum mungkin bisa mengirimkan suara kepada kita kalau tidak sibuk di Kalimantan Selatan.
Terima kasih.
Silakan Bapak Sekum.
Ya, selamat pagi semuanya. Terima kasih Bli atas penyelenggaraan relay kegiatan CPD Asia untuk kesempatan kali ini dengan host dari Myanmar ya. Mudah-mudahan lancar semuanya dan selamat menikmati materi webinar pada kali ini. Mudah-mudahan bermanfaat untuk semuanya ya Bli. Terima kasih. Ya.
Baik, terima kasih Bapak Sekum. Semoga lancar juga acara di sana Bapak Sekum.
Ya,
Lancar dan ya sukses. Baik, kita akan langsung menuju ke Myanmar untuk menyaksikan persiapan acara 17th CPD Asia hosted by MSMRT Myanmar. Sembari kita menanti kehadiran Bapak Gatot Santosa untuk dapat menyampaikan laporan kepada kami.
Will be with Hong Kong. The next CPD will be Hong Kong, the 18th.
Yes. Before the DN, I introduce to you and Nelson introduce something about next CPD.
Because Nelson will not attend today, I will be representing him to attend this CPD.
Yeah. You can introduce.
You want me to introduce at the end of this CPD?
Yes, Hong Kong.
Okay, sure.
Yeah. If not him and you also, okay.
Okay.
So it's time to start the introduction video. Thank you for all the presidents and panelists in discussion of the next Asia CPD. Ms. Yimon, kindly start the video now. Thank you, everyone. Our introduction video session is ends here. I would like to introduce Ms. Pichi Luna for the control of the continuous event.
Thank you. Hi, everyone from Asia and all over the world. This is Asia CPD, online continuing professional development platform for Asian Radiologic Technology Societies. And hosting the 17th CPD Asia is the Myanmar Society of Medical Radiation Technologists. And I am Pichi Luna, your program host. We are again grateful to our sponsor, VT Healthcare Vietnam, in helping us organize the online CPD Asia. And we are live streaming on YouTube. Please search PARI and VART channels. And so you may join us live and or watch a replay using these YouTube channels. So now to formally start the program, please welcome Mrs. Yin Than of the Myanmar Society of Medical Radiation Technologists for her opening speech and welcome remarks.
Hello, everyone. Good morning and greeting for the day. First of all, I would like to kindly welcome on behalf of the members of MSMRT to the presidents of the international associations, panelists and representatives and international imaging technologists who are attending the 17th Asian CPD. In addition, I would like to sincerely extend my greeting to the attending local radiologists and representatives from the various hospitals, MSMRT vice presidents and EC members and technologists, and those who are watching online, Facebook and YouTube channel. We surely hope that each and everyone will receive benefit from this webinar, which providing chance to combine and exchange knowledge with the advancement of technology. Furthermore, I really appreciate the ones who encourage me to be able to hold this event. I'm really thank you in advance for your attendance. Have a good day ahead, everyone. Thank you.
Thank you so much, Mrs. Yin Than of the Myanmar Society of Medical Radiation Technologists for that very warm welcome. This online Asia CPD is highly supported and raised by member societies, presidents, the officers and representatives. Allow me to recognize each of them. Let us greet and welcome President of Macau Radiological Technologists Association, MRTA, Fernando Kok.
Hello, I am Fernando, President of Macau Radiologic Technology Association. Good morning.
Yes, we also have, thank you, President Kok, President of Perhimpunan Radiografer Indonesia, Indonesian Society of Radiographers, President Giek Sugianto. We have the President of Vietnam Association of Radiological Technologists, VART President Thai Van Loc.
Good morning, everyone. Good morning. Congratulations, Myanmar Society.
We also have President of Hong Kong Radiographers Association, HKRA, President Wan Shu Bun Nelson.
Hi, everyone. I'm Philip Chen. I'm from HKRA, and many greetings to Myanmar. Thank you.
We also have the Singapore Society of Radiographers, SSR President Denise Chung.
Good morning, everyone. I'm Denise from SSR, and I'd like to wish everybody a very fruitful session. Thank you to the MSMRT for organizing this.
And representing for President Chun Yuan-tu of the Taiwan Association of Medical Radiation Technologists, we have Mr. Cheng Whitley of TAMRT.
Good morning, everyone. I'm Jiwan Lee, come from Taiwan.
Thank you. And then we also have President Sophie Lee of the Association of Cambodian Radiological Technologists. We have President of Philippine Association of Radiological Technologists, President Rolando Benares. And also joining us are our new member presidents from societies. We have President A. Selva Kumar for the Indian Society of Radiographers and Technologists, ISRT.
You unmute microphone. Simba, President Simba. You mute microphone.
Namaste and very good morning. Warm welcome to all from Indian Society of Radiographers and Technologists.
Yes, good morning. Thank you, dear sir. And President Tumi Barkant, President of Mongolian Society of Radiological Technologists. So also we have our invited panelists from different countries. So this time we have from Malaysia, Mrs. Chan Lai Kwan.
Hello, welcome everybody. Good morning. Nice to see everybody.
Yes, thank you, madam. Thank you very much, dear presidents, officers, and our dear panelists. Later, they will be joining us again during the Q&A session as our panelists. So may I humbly request all presidents and officers, representatives, and speakers to please open their cameras for a short photo session. All right. Thank you again, everybody. So to begin the program, allow me to briefly introduce our program moderator. Our program moderator is an imaging technologist of the OSC Ocala Special Clinic Hospital. Ladies and gentlemen, let's welcome to moderate the discussion and the different sessions. Let's have Ms. Mary Zin Soe.
Thank you, Ms. Pichiluna. Good morning, everyone. I'm Ms. Mason So, Senior Imaging Technologist at OSC Hospital. It's my absolute honor and pleasure to perform as the moderator of the ceremony for this 17th Asia's CPD online continuous professional development platform today. Well, according to the agenda, now we are going to start the academic section of the program, the very interesting and knowledgeable presentations by 4 speakers are waiting for you. Firstly, may I invite Mrs. Nway, Imaging Manager at Grand Hanthar International Hospital, with the topic of Radiologic Technologist Professionalism.
Hi, good morning, everyone. Today, I'm going to present about radiologist, technologist, professionalism. Before I start my presentation, I would like to thank you to everyone who join us today, the event, and all the organization support us for today's event, and CRG Prof Tene, who support me and guide me for this presentation, and Teacher Su that she came in to me personally and request like persuade me to participate today event, and 14-star team, like Dr. Kongyi in team on the 14-star. So today event is like we are working as a professional radiographers. So for all of us, like we already choose like these professionals, we cannot stop our learning and we cannot stop our education. So we all, everyone in our field have to continue our knowledge and continue learning. So I thank you to everybody who joined from internet and like to join the webinar and whoever arranged to begin this event. Now I would like to start my presentation. My presentation will be start with the ethics of radiologist technologists. For everybody working in the professional field, we all have compliance rules and ethics. Ethics is a moral philosophy or code of morals. We all, whoever participate, whoever practitioners, all we have to follow, and all we all have a standard protocol, and all we all know what is the ethics of our professionalism. And then it is an individual conceptions of right and wrong, and understanding, determinations, and motivation based on our individual conceptions of right and wrong. Then it is not determined by strict rules or like rigid guidelines, but all the ethics may change depends on our organizations and depend on situations. But we all must follow that ethics. Sorry, my slide is not moving. Yeah, no, it is not.
It's like a wow pin, sound pin. It's like it's not moving.
Yes, CRD. It is not moving.
You can stop say and you say again.
I think we are able to panelists at the channel through President Mr. Aung Joseph
Okay, Mr. Aung Joseph của Tin San Network cộng bên giáo bài xin học. Ta lý bị bài xin để chắc là học.
Mình chơi lỗ lồng được cứ đuổi lại vai ra mà bộ mà đi.
So can I continue, so?
Cái thứ lắm đồ cha mà bộ.
Suka kan ni pek, anu bakal video. Kau ni cha.
Yeah, much better.
Okay, let me introduce the Professor Hlaing, our radiologist in Myanmar. He is now joining the webinar. Sorry for your inconvenience.
Can I continue now? All right, sorry for inconvenience. Okay, so for the ethic, if we follow the ethic and our professionals, if we face any difficulties in workplace, the professional will help us to respond positively. And those are the ethics that I would like to introduce like code of the ethics. As we are choosing as we working as the radiologist, technologist profession, we all the behavior, all the words, and then we all do all the behaviors and all the what's supposed to be professionally, and we have to respond to the patient needs. We have to support each other like co-workers and associations when we are giving the quality care to the patients. They have not discrimination regardless of patient gender, race, or religions, or financial status, or languages, or age, or type of illness, or mental or physical ability. As we are a radiographer, we are using the X-ray machines to get the image for medical purposes. So we have to handle the machine into the patient as well. So when we handle the patient, we have to use the equipment properly, and we have to perform the procedure and technique appropriately by using our strong theoretical knowledge and concept. We cannot do anyhow. Then, as we are professional radiation workers, the radiation we use for the medical purposes must be minimized, and we have to minimize the radiation exposure to the patients, to ourselves and others professional healthcare also. So when we perform the procedure, we have to comply the LRL principle as low as reasonable achievable. Then even we make a mistake, we all have to take responsibility what we had done to the patients and what was our decisions. Then, as we are a radiographer, we are working as an allied health. We are helping the doctors and clinicians to get the precise diagnosis, to get the proper treatment. So we all have to assist the doctor, whatever the way we can help to the patients. So we have to, sometimes we have to assist the doctor like directly in operating, let's say like in operating theater, when they are operating to the patients, we have to help the clinicians by guiding with our CM. So we have to assist and help whatever way we can help to the clinicians and patients for the precise diagnosis and to get the proper treatment to the patients. We have to respect the patient privacy, and we have to maintain the patient's information as well. We cannot release any information of patients to the others rather than patients. Then as I said it before, we are working as a professionals workers. So all professionals, we have to maintain our ability and personal growth by continuous learning. Sometimes some of the cases and some of the technique is like very rare case and unusual cases. Only once in a while come in for the request. So if we are like once the rare case is come in, this time you can perform very good, but when you never do for a long time, you may forget or you may encounter before. Then when the request came in for the next time, you may not know, or your standard might not be standard, your performance might not be standard. This is not the way we have. We cannot. So for us, for professionals, every time, every performance must be consistent. Then when we have to answer the patient questions and patients' families, we have to answer fully and honestly within our limits of knowledge, authorities, and responsibility. If the question is beyond your limit of knowledge or authorities or responsibility, you cannot answer, and you cannot say no, or you cannot say I don't know. You have to refer, or you have to redirect to the person who can answer the patient's question appropriately. Those are the ethics we have to follow and we have to comply. Now, after this, I would like to emphasize is how are we going to perform professionally when we are giving the qualified patient service care. Then, first of all, patient safety is the most important things. For the patients, when they came into the imaging department, the duties of our radiographer is we are helping the patients. So in our hand, nothing can happen or nothing can happen, any potential risk to the patients. So patient safety is very important to us. Like, let's say like for the infections control as well, that we have to break down any potential risk or infections control from patients, from us to patients, patients to patients, from us to among co-workers as well. Like safety, sometimes it's like some small things can happen, big things. Let's say like when there is a water drop on the floor from the ceiling, then nobody noticed, then patient come in, patient may slip and fall. If we notice that, we have to call the housekeeping to clean it right now, or if we cannot reach to the housekeeping, we have to put the warning sign for the notice. Then sometimes may happen is when the patient is transpiring, when we transport the patient from CT table to the wheelchair, or from the MRI table to the wheelchair, or from the X-ray table to the wheelchair. Sometimes what happens is patients came in with a wheelchair, but they can move on very well. But when they wear their slipper, then may slip and fall as well. So for us, every movement we have to be careful for the potential risk for the patients, especially for the pediatric patient. And then for the, as I said before, as we are working as a radiation workers, for the radiation exposure also must be as low as possible. And then for the, especially for the magnetic field for the MRI machines. And for us, like for the imaging technologists, we all know what is the harm or the strong magnetic field, but for the patients, they might not. And then for the others, like not from the imaging department, so we have to educate to the patients and the co-workers and then all the other medical team. Like we have to notice and we have to train them. And then in our hospital as well, we have to educate them how harmful to that machines when we are careless go into the room. For the, like sometimes for the assistant, for the imaging assistant person, like nurse aide, we have to educate them before we go into the machine and before they start working at the imaging department. That is a very important for the potential risk of the patients and our surroundings. Then we all have to respect other health professionals as well and communicate with them very well for giving a quality care. Let's say like we are not very sure what they write on the request form. If you don't understand it, you have to clarify and you have to make sure what they request for the imaging service. Like if you, let's say like I am not very sure what is the request, so we have to approach to the clinicians or we have to approach the referral doctor personally. If we cannot reach personally, we can call them and clarify what is their request and what they want us to be done. So when you call to the other person, you have to respect that person and you have to respect yourself also. So when you call someone, you have to introduce yourself that, okay, I'm calling from the imaging department regarding about this request form. I'm not very sure that you can call it. Then when you listen to the phone also, sometimes we have to be careful. We cannot mishear what they write, what they are saying or what they are instructing us. So if you are not clear that what they are instructing, you have to question back. We cannot afraid or we cannot sometimes we scared to call to the clinicians because they are professors. Sometimes the clinician is a professor, but we cannot proceed the imaging examination without knowing what they request and what we have to be done. Right. Another thing is our performance must be consistent all the time, and in our imaging all the time in all the imaging person must be consistently. So we have to engage our learning along life. So that means we have to continue our learnings. Another one thing is like we cannot engage in any personal relationship with patients. Like we cannot abuse patients sexually, emotionally, socially, or financially by using our position. One more thing, important thing is, as I said it before, all the radiographers in the one department, our performance must be standard and consistent. That means in our department, let's say like my department, like there are 10 or 18 radiographers. All the radiographers, they have their own way to perform their examinations, but you can perform the examination by your own way, but all the outcome of our performance, all the images must be standard and optimal for the diagnosis purposes. You do your own way, I do my own way, but all the outcome could not be consistent. That is not the quality care to the patients and to the other clinicians as well. If our request, when we see the request for this request for the procedure is beyond our knowledge, you cannot do anyhow. You have to refer to the person who can perform these examinations and who can perform this technique to the this techniques. Then some of your performance and your knowledge have to be up to date. So now I would like to emphasize is that how are we going to improve our knowledge? Nowadays is like last time we have a lot of limitation to attend a conference or like attend a webinar. Like nowadays is very easy. You don't need to travel to that place, and personally we can attend all the professional meetings and conference by clicking internet. Like right now, and all over the world they can join if you get the link for the conference. Then sharing is another thing is that sharing is the power and sharing is a caring. For us, the professionals workers, we have to share our knowledge. We have to share our experience. Then for the learning is there may be a different way. You can read from the books, also you can learn it from the radiologists who are reporting your images. Then if you don't understand what is a request, also you can approach to the radiologist. Radiologists will guide you how to perform what they want it to be to get the images. Then some of the experienced seniors as well, seniors and co-workers. Some experienced seniors and co-workers, we can share and we can teach each other. We can get our knowledge from each other. Some more seniors and colleagues also, we have to share our knowledge. Sometimes some people thought, oh, this procedure only I can do. I don't want to share to others. This is not the professionals. For the professionals, let's say like in my department, there are like 8 or 10 CT radiographers there is. Then the virtual colonoscopy is very rare and very unusual cases. So like only 2 or 3% can do that virtual colonoscopy. So if patient come in, if that person not around, then they cannot do the procedure. No, this is not a professional service, and this is not a standard service. So for this kind of things, if you know how to do this, you have to share and you have to teach them, you have to guide them how to perform and what is the preparation, how to do it. And the same thing also in the general X-ray, also like scoliosis Hlaing is very rare and unusual. So only you can do that, you don't want to share to others. So when the patient came in, patient have to reschedule for this examination and come back again. This is not a standard and this is not a professional care. So if you know how to do this, you have to share and you have to teach all the radiographer in your department what is the way and what is the standard, what's supposed to know and what is the qualified, what are the qualified images and what is the things that clinicians wants us to be done. So that must be a professional. Nowadays, we all can access the internet as well. So there are a lot of free internet websites for us to learn. I want to share some of the websites. So these are the very famous websites. Like right now we are doing an MSMRT website, the Radiopedia for the MRI. For the CT also there is a website, and then the Radiologic across border as well. There you can learn a lot of their conference. And then those are I just show you the sample. The Radiopedia, and you can type on the search box and then you can read it, and then some of the images and some of the articles and indication, the images, and what is the technique they wrote it there. And this is for the MRI. There are a lot of the protocol here. Everything you can rely on that this website, and you can learn. This is for the CT scan. There are a lot of protocol they wrote it here, and all the images also you can learn from it. Then, sorry, I wanted to introduce about the radiology across border. Radiology across border is there are a lot of webinar, and every month they doing the webinar. And then for the radiologists, for the technologists as well, there is a talk. For the technologists, like almost every week, every month, they have a webinar. So we can learn it from there and we can listen. So for the conclusion, take-home message is like we have to comply all the safety rule to the patients. We are helping the patients, so we have to stop every potential risk from us to the patients, from the patients to patients, then patient to us, no relationship with patient. Then we, as I said before, as for the professionals, we have to keep our learning from everywhere we can get it. And then the most important thing is that we have to share our knowledge to others, and then someone we have to educate to the person. And sometimes we need to educate to the patient as well. So those are the references that I read for this presentation. And thank you so much. Any questions you can ask me.
Thank you so much, Ms. Nway, for your interesting and wonderful presentation. To continue with the program, we are warmly invite Aung, imaging manager at Hlaing Hospital, for the topic about scanning technique and critical findings in chest CT.
Good morning, everyone. While we are preparing for my presentation sharing, first of all, I would like to express my gratitude, firstly to the Asia CPD organizer and planner, and all the leaders and chairmen and all the members of the International Radiologic and Technologist Association, and also to our MSMRT, and all the attendants, my senior colleagues, and all my teachers. And I do remember our CRU came out there because he will be very happy to see this event happening. And personally, I also feel sorry that most of our colleagues, teachers and senior colleagues from the government sector are not being able to attend or join in this CPD program. As you might already know, we are not in the normal condition yet. Our healthcare system is still in the chaotic situation. We are trying our best to cope it. So the reason I participate and join as a speaker in this program is that we have many more knowledgeable senior colleagues in our technology. Yeah, it would be very great if they can present and share their presentation with us. They will be much more knowledgeable than I do. but I'll try my best to show our commitments and passion to our professionalism. So whatever situation it is, if the private sector will be serving our best, if the government sectors are not being able to participate very well. So this is my intention of joining this program. So before continuing to my presentation, I would like to introduce about myself a little bit. As I'm a Medicare Radiologic Technologist, I graduated from the University of Medicare Technology, Yangon, Myanmar. We have two universities in Yangon and Mandalay. And I also achieved the Master in Business Administration degree. And as for my employment history, I'm currently working as an imaging manager in Hlaing Hospital. Before that, I worked as product and application manager in Siemens Healthineers. So before that, I started my career as a radiographer since I've graduated continuously at the Hlaing Hospital. I would like to briefly share about the hospital I'm working at. So Hlaing Hospital is one of the largest private hospital in Myanmar, and we are the flagship for the nationwide. We have many more branches to make the better reach for to serve the entire nation to our best. And our main focus is international quality. The reason why I introduced my hospital is the topic I'm going to present today is much more related to the quality measure. So to achieve our commitment to the international quality, we also try for our best to comply with all the JCI standard, and currently we are the only one JCI accredited hospital in Myanmar. But I'm sure there will be many more hospitals achieving JCI. So this is the brief outline of my presentation contents today. So today I'm going to talk about the critical findings. So as a radiology technologist, we have many roles and responsibility in daily life. We need to know about the machines, we need to know about our scanning techniques, and also we need to know about the patient safety. So as a radiographer, most of us trying to be competent in day-to-day scanning and trying to produce the best images. And then I just would like to add a small chapter about the small chapter, but most important chapter. When we have achieved the very good quality radiograph, we are happy most of the time. Okay, if we see a critical finding, let's say for CTA, if our CTA images are very nice, we are so happy. But sometimes, depending on the hospital setting, we might or might not continue the process for the patient safety. It's like informing the critical findings. So we just enjoy our images. Well, I don't mean to all of us. Yeah, some of us doesn't know that we need to inform this immediately for the safety of the patient to have the effective treatment for the patient. So the topic I selected today is about the critical findings. So there are many more critical findings in all the scan area or the anatomical area that because of the time constraint, and I'd like to just express about the critical findings in the chest, CT. So the major critical finding will be the pulmonary embolism and the aortic dissection. So I will talk about these two critical findings. And what are their signs and symptoms? What are the risk factors? What are the clinical indicators? What are the investigation methods for them? And what are the limitations? And what are the scanning technique, most importantly for our technologists, and a few case studies. Yeah. So most of us, most of us have already understand what are the critical findings. So today my sharing slides are usually intended to the person who doesn't know much about the critical findings. What are the critical findings? It's a value of results. Maybe a radiological critical findings or the laboratory findings. What I'm going to talk today is about the radiological critical findings. So it's a value that falls significantly outside the normal range, maybe for the lab test also, this is outside the normal range, but it must also represent the life-threatening values. So we don't need to inform all the other examination results that are deviated from the normal guideline, but we need to inform them if it represents the life-threatening values, so that the appropriate corrective action can be taken or the better treatments of the patient. So who need to understand about these critical findings? Or the doctor, nurses, and allied health professional, like radiographer, laboratory technologists, and all our allied health staff, they need to understand what are the critical findings so that we can inform them the finding immediately to the care provider or referring doctors or attending physicians. So it finally goes to the quality care and the safety of the patients to ensure they achieve the appropriate diagnosis and treatment timely. So these are the just brief displays of critical findings radiology. They are in the head and neck region. We have critical findings like scalp fracture, hemorrhage, and herniation syndrome, and cerebrovascular accident. So some critical findings need to be informed by the radiographers, and some need to be informed by the radiologists, because it's kind of pathology and diagnosis related, right? So not all radiographer might be able to identify these findings on our radiograph or diagnostic images. So some need to be identified by the radiologist. Why some can be identified by the experienced senior radiographer? Why some can be identified by the radiographer? So it's very important for us to know what are the findings and also educate each other so that all our members, let's say a general radiographer, they need to understand the complex scalp fracture. They must understand that this is the critical finding, let's say a pneumothorax. So all the radiographer, it must be able to identify these critical findings according to their levels. So general radiographer must be able to identify the findings on the general radiograph. So it's the same for the CT technologies, and those are the findings in the abdomen, spines, and pelvis areas. Some of the findings in the ultrasound, like ectopic pregnancy. So I won't go line by line with details because you all might already know, and you can easily find these critical finding charts in the many references. So it is very critical to understand what are the critical findings. So but today my topic is about the chest, critical finding in chest. So the major critical finding is the pulmonary embolism. So embolus in the pulmonary, it is very critical for the patient. We need to inform appropriately. The second thing is the aortic dissection. Dissected aorta, we all know that it can generate a very critical situation for the patient. The blood supply can be stopped depending on the extent of the dissection, and it can also eventually generate to the aneurysm and also rupture. So it's a very critical finding. And other general radiographer, they need to identify the line and tube displacement. So for the chest, especially when going for the portable X-ray, some of the patients with the central venous catheter, and some are with the nasal tube, some are tracheotomy tube, some are drainage tube, etc. So we need to identify these tubes. Yes, we are not putting this line, and but we need to understand where they should be when we need to inform. We need to inform them if it is not in the appropriate position, because it won't be safe for the patients. So let's say if we have done the portable X-ray, but if we don't inform the attending physician, it might be able to save the patient in the next day. So in this day, the nurse, if they don't know that the tube is in the misplaced position, they might give the injection through the line. So it's very dangerous for the patient. So for the general radiographer, whenever we are going for the portable X-ray, we need to check if our image quality is good. Yeah, but secondly, additionally, we need to check all the lines and tubes are in place or not. If not, we need to confirm the finding, then we need to inform it immediately. And also for the tension pneumothorax. So some should be, as I mentioned before, some finding need to be confirmed by a radiographer once he can confirm the finding. So for the junior radiographer, they might not be able to identify it, doesn't matter. They can always escalate to the senior radiographer or the radiologist for the finding confirmation, because critical finding usually come from the times of the confirmations of the findings. So we usually from radiology side, it depends on the hospital, but in our hospital, we need to inform this finding within 50 minutes after the confirmations of the finding. We need to escalate it to the attending physician or medical officer. Then they will, let's say if we are informing the medical officer within 15 minutes, the medical officer need to attend the specialist who is given the expert opinion for the patient within 15 minutes. So the patient get the appropriate guideline for the treatment within the 30 minutes. So this is our goals of critical findings and reporting. Not just reporting, we need to record that we have already reported the findings. So this is for the one of the quality improvement indicator as well. How many critical findings are there in our department radiology, and how many we have reported, and how many we have reported within the time frame, and how many we couldn't report it within the time frame. So what are the outcomes, etc. So for pulmonary embolism, we all know that a thrombus in our venous systemic system from the leg or heart, they can eventually reach to our pulmonary artery and becomes an embolus in there. So how we can know that the patient can have the pulmonary embolism? So those are the signs and symptoms. Usually they have the chest pain, help on breathing, the difficulty in breathing, and shortness of breath, and some have the fever, and sometimes because the blood is in the respiratory system, so some coughing up of the blood, and it is a kind of venous thrombus, so they will usually have the leg pain or swelling. It is subjected to the our deep vein thrombosis. So the patient can have the excessive sweating. Those are the signs and symptoms of the pulmonary embolism. So why do we need to report pulmonary embolism? Was this very critical? 1.5 out of 1,000 people have the pulmonary embolism. So prompt diagnosis and treatment is essential. We need to give the anticoagulant treatment. It need to be in place in the right time before the case getting severe and life-threatening. That frequently occur within the first hour after admission, especially for the patient who didn't receive the X-ray clinical examination and didn't receive the anticoagulation therapy. So in severe cases, it can induce the right heart failure. So because the pulmonary artery, there is a thrombus, right? So the blood cannot pump up to the lungs appropriately, then the right heart has a burden, and the entire circulatory system will be collapsed, and eventually patient can become dead. So that's why this finding is very important, and we need to inform it. But we also need to identify that this is the first finding or the follow-up finding. If the follow-up finding, we don't need to actually inform it because physician already knew that the patient has an embolus. So they just following up the cases. So if there is severe cases worsening, then we might need to inform. But the patient is getting less or reducing in size, it might not be identified as a critical anymore because the physician already know the case. So what are the risk factors? As you all know, is the increase in age. Our blood vessels, they are not as good as the young people and more prone to the thrombus formation and the previous venous thrombotic diseases and instrumentation. Like if we put our foreign body inside our body, they can generate more thrombus formation around it. So people with the cardiac stenting, they need to get the anticoagulant therapy because it's also more prone to the venous thrombus formation and also other diseases like neoplastic diseases and immobilization. The patient is very sedentary lifestyle, is not doing regular exercise or walking, and this can also generate to the pulmonary embolism and also surgery. As an impact of the surgery, there can be a pulmonary embolism. So other hypercoagulated states and hormonal therapies. Women's they are not old, but they're taking the oral contraceptives. These are also prone to the pulmonary embolism. So all these risk factors like pregnancy, and we need to understand it before we scan it. Okay, we can have the finding or not, like predicting the outcomes before we continue scanning. So in a way, we can be more alert. This patient can be in the highest risk factor. So knowing that, we can also able to identify. Sometimes the case the doctor will just refer as a CT contrast. Then we have many protocol, right? CT protocol or the usual contrast enhanced protocol is different. Injection rate, flow rates, and timings all are different. So knowing this risk factor, if patient has one of the risk factor, we must think that if the patient is just ordering, physician is just ordering contrast enhanced CT, but we must know that it would be very informative if we can include the pulmonary arterial phase for the patient. So this background knowledge will help us for better scanning technique selection. So this is just for information. These are the clinical indicators of the pulmonary embolism. There are many indicator calculating formula like Geneva scoring. This is the well scoring. So we can easily find it in the internet. So if the patient is one of these factors like a previous PE or heart rate more than 100 or surgery, it's kind of previous mentions in the slides, the risk factor, right? If the patient has one of them, the score is positive for either one of them, more than one can be in the new simplifying score. If the patient is matched with the more than one criteria, it is considered as the pulmonary embolism is very likely for this patient. So if the patient is indicated for all these parameters, very, very, very highly likely. So if the patient is less than or equal one score, it is quite unlikely. And what are the investigation method for PE? We all know the CT is a very preferable method. It is also very fast and also quite affordable. And that is when the patient is usually referred for the CTPA. Firstly, the doctor, attending physician or doctor, usually they have the clinical assessment. If they have highly clinical suspicions, like that the previous risk factor is, he has high risk factor, and matching with, more than one of these factors and highly suspicious for the pulmonary embolism, they usually refer for the CT. And for the low or moderate suspicion, is not very much suspected, but we usually do the D-dimer test, right, for these kind of suspected inflammations or thromboembolism. We usually do the D-dimer test, right? D-dimer test positively higher score than the normal range. Then CT is also referred by the clinician, and so the CT will also always stand fast in Myanmar as the most preferred technique to identify PE. And another thing is VQ scan. VQ scan is in a way more like, we have to say that it's like a nuclear medicine kind of thing. Is radio tracer injection for the pulmonary perfusion, and another is for the ventilation. It's inhalation is of the radioactive gases, and images are scanned with the gamma camera. So it won't be feasible solution because of the limited available scanner in Myanmar. So CT will always stand as a most preferable methods for investigation. So laboratory test is not a indicators of the PE, because it can be increased in any other diseases as well. This is just used as the other factor of the possible risks for kind of a low or moderate suspicious PE. So the incident out of the suspected cases, when we see the CDPA, not all the patients are positive. Only 10 to 30% among the suspected cases are found as pulmonary embolism positive. So for those cases, we also associated with the deep vein thrombosis in 70% of the cases. And what would be the limitation of the use of CT? We have some other kind of drawback from the CT, use of the CT, because we need to inject the contrast medium So some of the patients like a chronic kidney disease and without the proper plan for the dialysis, they won't be able to proceed with the CT because we need to get the iodinated contrast. And some have a severe allergy, but for allergy, we have the protocol for pre-medication. Yeah. So, but these can be, these factors need to be considered and all the possible risks need to be minimized with our pre-medication. And the other thing is it's really protocol dependent. If you're not using the appropriate protocol, your correct scanning phase can be missed out. Then you are not getting the right timing and you are not getting the pulmonary angiogram images. It will be delayed like the aortic phase. So you cannot able to identify very well. So another thing is it's also patient dependence. The patient has a cardiovascular status, means we cannot know his cardiac output. And other thing is he might have a kind of, congenital deformities like having the, like say, subtle defects like that. Then you will not be able to get the right contrast bolus timing because of the patient has a congenital problem inside, right? So, and then ability to be able to cooperate. We need to be very careful with the breathing instructions. Some patients think we're unconscious and they are not able to cooperate with us for the breathing. And some are, even foreigners, it may be easy because in our scanner, we are able to select the languages. But for the uncooperative patient, it's really difficult because patient cannot hold the breath and we don't have a sub-second scanner yet. So it's also the factor for consideration. The other thing is the body size and whether if the patient is too big, it's we can have more noise on the image quality. Then some of the mixing artifact we can have it because the timing is very important. And if we are giving more, then we will have the artifact from the SVC, right? The venous artifacts. So if we are giving more saline cheese and sometimes if our timing is late, we can have the contrast saline artifact. So we don't recognize very well. These can be mistaken as pulmonary embolism. So the other things of the beam had any artifact, as I mentioned, from the superior vein cables, we had any shadow cascading on the areas of interest. We cannot identify the embolus in that area. So these are the limitations for the use of CT. So we can also experience the suboptimal contrast enhancements. When do we usually see it? When we place our RI in the incorrect position. And the other point is we put in the correct position, but the RI move to the patient is breathing. Right? In our scanning, we give the patient a breathing instruction in scanning, but in the trachea mode, we cannot tell the patient to hold their breath. So there is slight variation between the trachea and the scanning phases. So sometimes your RI can be moved. So we need to be very careful that your RI will not be missed out in any phase of the respiration. So the other thing is the incorrect threshold hands free. So we need to be very fast in scanning the pulmonary embolism. So sometimes we forget to change the threshold hands free. Let's say we put it to 200 hands free. Then when at times of the scanning, it can be very late to achieve the scanning. So the other thing is Vasava. Vasava is very important. Most of us didn't aware of it. We are very used to giving the breathing instruction to the patient, breathing and hold your breath. The patient is holding his breath and his abdomen is like we are doing the Vasava maneuver. That kind of situation will generate the pushing up of the contrast median to the superior vena cava. So you will not have a good bolus of the contrast in the right ventricle. That is the roots of the pulmonary trunk, right? So this also generate to the suboptimal contrast enhancement. How can we identify it? We can usually identify it when you find a lots of accumulated contrast in the SVC. In the meantime, there is a contrast in the aorta, but contrast in the pulmonary trunk is missing. Then we can identify that this is due to our incorrect breathing instruction technique. So it is very much favorable. In the new study, it's also mentioned that expiration and breathe is recommended. If we are not very sure, then we can tell the patient to have very shallow breathing and hold his breath. This way, we can avoid the bursaver and suboptimal contrast enhancements. So these are the scanning technique for the CTPA. All the experienced senior CT technologists know how to scan it. So roughly, our scan coverage need to cover from the Hlaing apex to the diaphragm level. But if the patient is very young and pregnant, we need to reduce the potential of the radiation risk by hazard. And the young patients, we can narrow down the scan coverage a little bit from the arch aorta to the below heart levels. So for the slide thickness, it need to be very high resolution. So we can all reconstruct larger than 2 millimeter slide thickness. It is very much recommended to use the less than 2 millimeter slide thickness for better accuracy in interpretation. So the KV method, we all know that we usually use the 120 kVp technique, but for the younger patient, we would like to reduce the radiation dose to low as possible, and we have with the upcoming scanner modification, we are able to select kVp range in some scanner, and for the young patients, we can use the lower kV techniques, which will reduce the contrast usage and also radiation dose to the patients. So this is also a wide chapter, so I will mention many more details about it. So MA is also the same with our tube current modulation. We can combine our reference MA 200 or 150. So for younger patient, we like to use the lower dose. So we reduce the MAS for the younger patient. And scan time, less than 3 seconds is preferred. We need to be very the contrast column in the pulmonary trunk, not reaching very late to the aorta. So our scan time is less than that, 3 seconds is preferred. So injection rate, we all know that we need to give 4 ml per second. It should be the minimum rate, because less rate, we will have more prone to a mixing artifact. And also, I just mentioned the contrast name, but actually the background behind is if we are using 350 milligram iodine contrast median or 300 milligram iodine contrast median, visibility is the low osmolar contrast, and the iodine index inside is 300 milligram iodine. So for the bigger patient, it will be like more diluted images. So the bigger patient, Omnipaque will be a better solution. And the injection rate will depend on the patient heart rate. A higher heart rate and more cardiac output, we need to get the faster injection. So some of our radiographer, we don't usually take the patient heart rate. So it is very highly recommended to take the patient vital sign to know the patient heart rate so that we can determine which kind of flow rate would be appropriate for the patient. Then we can avoid the suboptimal contrast enhancements. So contrast injection duration, it actually depends on the scanner. And injection duration is the faster the better your scanner performance, the lower you can reduce the contrast injection duration. When this is practiced with our hospital study, we usually give 10 to 12 seconds. Actually, our scan time is around 3 seconds only, right? But we can all know the patient is his circulation and contrast arrival time. So, and also we have the delay from the tracker to the actual time of the scanning. So there is a gap, right? Scan delay. So to cover this scan delay, we usually inject more than the scan time. It's usually 10 to 12 seconds. So to use how many contrast volumes needed, we just can multiply with our flow rate, right? If you're using 5 ml per second for 10 seconds, we are using 50 ml of contrast. So personally, I don't prefer using a lot of contrast for these. So I usually calculate it with the scan time and the volume I'm giving to avoid the artifact from the venous system. So saline flash is very important. I use the more saline flash, like 10 seconds saline flash. So RI can be put in the pulmonary trunk, but if your scanner is slow, especially our scanner is a bit slow, so I usually put it in the right atrium. And the threshold hand speed is also depend on the scanner rate. Faster scanner, you can put 100 hand speed, or some people put 120 hand speed. But for us, it's best to put 60 to 80. And the time delay for acquisition is actually a machine-defined delay, right? Because we are giving breathing instruction, this delay cannot be avoided. Time delay for acquisition will be 4 to 5 seconds. So I will just go very roughly about this case study. This is the first case is 52 years old male. The patient came with some chest pain, so it's one of the silent symptoms, suspicious of the pulmonary embolism, and he arrived on day 1. The chest pain, it gets worse, and he has shortness of breath, all of the silent symptoms of the PE. He went to nearest clinic at 9 p.m. But luckily, the doctor gave him started the anticoagulant therapy in the clinic, and then he was referred to a Hlaing hospital. And the patient is he has a fibular fracture 7 days ago on POP. So he has more than one risk factor for PE, and his family has a history of the aortic diseases. So when the doctor referred for the D-dimer test, D-dimer is also high, 15.3. So patient arrived at day 1. And the CDB order on the day 2, immediate order, we scan almost immediately. So knowing that the patient is a critical condition, we need to consider with our scheduling also. We need to give the patient priority and schedule as early as possible. We get his scan done at 10:50 a.m. and we found it, and we informed the finding within 15 minutes. So these are the findings for him. As we can see, there's a thrombus on both sides. So I won't go very much in detail to catch up with the timing. So outcome is with our immediate findings and reporting, that the doctor can better decide, right, with which anticoagulation therapy need to be proceeded. Like he can also able to adjust the dose, right, depending on the severities of the pulmonary embolism. Luckily, the patient can discharge from the hospital on day 5 with vitals stable, and he was advised to encourage and proceed the chest physio and breathing exercise. So the patient had a good outcome. The case 2 is also the female, 68 years old female. This patient, she is coming with the cardiac pathology and admitted to the cardiac unit and did standard to his left circumference vessel. And then this case, I would like to mention that after surgery or the post-instrumental implementation, there is a risk for the PE. So at the first time, we all can see that there is no sign of DVT for this patient when she arrived for his coronary artery treatment, CAG. And then on day 5, she had started the unilateral leg swelling on the right side. So this can be taken as let's say consequences of the pulmonary stenting, and this is common. So here CTP and D-dimer order. D-dimer is also it's about 5. It's also high, and anticoagulation therapy is initiated because for all the cardiac standard patient, anticoagulation therapy is already initiated. This patient also had a good outcome and got the discharge on the day 7 with stable vital signs. So these are images, thrombus on the right and left pulmonary trend. So sometimes we also need to reconstruct MIP images for better visualizations of the thrombus and the blood vessel. So those are the CT findings. So I will quickly proceed to another critical finding is the aortic dissection. We all know there is a tail. We have layers in the vessel, right? So one of inner layers of the aorta has a tear for many reasons, and then dissection can happen, right? It's kind of blood is draining in the false lumen, right? Incorrect lumen. So for the, let's say from the renal artery, for the dissected cases, the blood passing through this dissection, it cannot supply to the renal artery, right? So it's very important, and it can quickly lead to the death because of the insufficient blood flow and to the heart rate. Now, also, it's like balloon, right? Dissection can become bigger, and then it can become rupture. So it's very dangerous or life-threatening. So we need to inform this when we notice this aortic dissection. So these are how we usually see on the radiograph. So what are also the sign symptom? Is sign symptom with the aortic dissection and the embolism are quite common, like a severe chest pain and upper back pain. Patient will have the vomiting, sweating, and patient can also have the stroke, ischemia, rapid heart rate, heart failure, cardiac arrest. So weakness in any limbs. These can also be the signs and symptoms of the aortic dissection. If untreated, there are major two types of aortic dissection. For the type A, it's very critical, and then half of the people will die within 3 days. And then 10% of the people with the type B will die within 1 month if remain untreated. So they can have angina, severe heart pain and heart attack, and severe headache and abdominal pain, back pain and hypertension if remain untreated. So we need to inform it promptly and get treatment in time. So this risk factor is more common in male and over 60 years of age. So only 10% is occurring at the age of 40. So if you have a high blood pressure, because your vessels are not patent anymore, and it can have a leak and easily have a dissection. If you're a smoker, your vessels are not good. You're using drugs and also thoracic aortic aneurysm. All these kind of risk factors can contribute to the aortic dissection. So what are the investigations we can do for the aortic dissection? We can do chest X-ray, but we cannot totally identify there is a dissection or not. We can do ultrasound and Doppler. We can also see it in CT scan. We can also exclude the dissection, and also we can identify if the patient is undergoing other treatment for the grafting, etc. We can identify with the CT very well. And we can also do it in the MRI, but MRI is not very common in here because of the patient affordability and the availability. CT scanner are more abundant in our country, and we can also do the echocardiogram and the lab test. So what I'll talk about today will be a CTA for dissection. So advantages, CT is very sensitive and specific, 96 to 100% specificity. So what are the disadvantages? We need to, as we have already know, we need to give the iodinated contrast median. And also one more point is with MRI, we can diagnose the sites of intimate hair, but CT is difficult to identify it, enable to diagnose the site of intimate hair, which site it is at. So these are the techniques as usual. So I won't go very much in detail. The injection rate, it would be better if we use a faster injection rate, like 5 ml per second. And the contrast injection duration will be, it depends on your scan coverage, right? Usually we need to cover our scan from the, this is for the chest aorta, let's say thoracic aorta. So it will be sufficient if you cover from the thoracic inlet to the levels of 2. But for the most of the clinician, if they are willing to rule out the entire aortic dissection, we need to cover both thoracic and abdomen aorta. So then you need to cover up to the iliac bifurcation level. So depending on your scan type, then you will need to adjust your contrast injection duration. And the live flash is a must. Threshold, you can set 100 Hz or 120 Hz. No need to be much lower down like you did the pulmonary embolism. So you don't need to be very fast in this. This is a case study of the 77 years old female. He has the chest pain and hypertension, the risk factors for the aortic dissection, family history of aortic disease, and suspected coronary syndrome. And all the tests she done, and the lab test is D-dimer is increased. So D-dimer can be increased in aortic dissection or aneurysm or inflammation. So we cannot say with D-dimer you have the thrombus or dissection. You cannot say that it's not specific, it's just a supporting factor. So in chest, if you have the dissection, you will have the mediastinal widening. So what you can notice is if you have the mediastinal widening, then it can be an indicator. So aortic dissection type A is from the ascending aorta, and is approximate to the right main renal artery is found. And then treatment for her was replacement of the ascending aorta and approximate branch were done with the grafting methods. So this is just for information. So these are the images of our dissection images. These images were taken from our Taunji branch. One of my colleagues, we usually have the CPD program across the branches, and she presented this case in her presentation. So I just show the cases from there. Case number 2 is the patient has a stabbing injury to the chest, and he has no pneumothorax or hemothorax, lens clear. But there is, you can see the right widenings of the mediastinum and right tracheal region. Right. So, in possible mediastinal vascular injury, then proceed for the dissection. But this was kind of just the CECT, not CTA protocol. But you can see that there is a dissection in here. But usually stabbing injury is not related to the dissection. This may be the incidental finding. So we can see that 48 years of age, but he is a male patient. He can also have the dissection, but he is type B. So these are the 2 cases for the aortic dissection. As a conclusion, critical findings is also a wide chapter, and we need to learn a lot to understand what are the findings. So as a conclusion and take-home message, I like to say ABC, we need to always aware the patient clinical history, what are the symptoms, what can be expected, so how we can adjust it, which protocol will be the optimum for him. That is a background logic we need to consider before scanning a patient. Maybe a referring physician can just ask for CCT, which phase we are having. It depends on our awareness of the patient clinical history, sign and symptom, what can be possible, and applying the best scan technique. Let's say if the patient is highly suspicious of the PE, then we need to include the PE phase, like the CTPA phases, and then post-contrast delay phases, etc. So we need to make the best scan techniques, maintain our best scan techniques, and seek for improvement. We need to learn from our images, right? Sometimes we also miss the contrast timing, right? Then we need to consider why our timing is missed. If our result is unsatisfactory, we need to find a solution, do for the betterness next time. So the third is the communication. We need to have emphatic communication from the status of the patient journey, right? To have his communication and cooperation is there for the uncooperative patient. We need to have a better communication with patient, explain them very well, and then we have their cooperation and we have better images. That's again, communication is with our referring physician. We need to communicate whenever we find the critical findings. So first of all, we need to understand it. Then we need to communicate them. So to understand it, if we don't able to identify the file, we cannot able to report, right? So it is very important. I would like to emphasize again that our competency need to be maintained and our knowledge need to be polished. We need to understand. Though we are not radiologists, but we need to understand the critical findings so that we can save life for the patients. So communication is very important. They don't deviate from our safety guideline. If the guideline is set for CDP and the timing, let's say this is our standard timing, all right, we need to put in the main pulmonary trend or the right ventricle. We need to follow the guideline. Deviating from the guidelines, we can have a degrade in our quality, and ability to diagnose can also be minimized. So it's very important not to release our suboptimal satisfactory images. Some of the suboptimal images, so the radiologist won't be able to give the clear-cut diagnosis. So then it is not fair for the patient. They are not getting the right treatment. So if you find, severe timing missing out or something like that, then please repeat it. So don't pass or release your suboptimal or unsatisfactory images. And yes, we need to try our best to make sure all our images are accurate and diagnosed it at one stop to avoid the repeat to the patients. And E, we need to educate ourselves from learning. And CPD, we can learn from CPD. And the most important is we need to learn by doing, right? Learn from our daily activity. If you do very well, yes, appreciate yourself and maintain it. But if you have unsatisfactory result, learn from it and do for betterness. So these are my take-home messages for today. Those are the reference. Thank you so much for your patient participation and all to other online participants. Thank you so much.
Thank you so much for sharing techniques built on based on your own experience in your very informative presentation. Thank you. Well, the next speaker is Ms. Nway, Chairman at KNY Company Limited. We are very pleased to hear from Ms. Nway with the topic of imaging modalities of mammography.
Hello, good morning, everyone. This is Nway, Chairman of KNY Company Limited. First of all, I would like to say special thanks to MSMRT and all presidents from Asia CPD, giving me a chance to join this great event. Thank you, especially thank you all participants and 14 Star Company Limited. And then I would like to, in here, I would like to share about the topic, imaging modalities on mammography. Thank you, Teacher Yin Dan, for opinion about that topic. Okay, actually, this topic is very, very familiar with us. So I prepared a few slides. Let me start my presentation. Please enjoy my presentation. Sorry for your holiday. Thank you for that. Today, my topic is imaging modalities on mammography. Actually, we are using current imaging modalities for mammography. Actually, breast imaging is very, very essential for female breast, elderly, and menopause, for especially younger patients, according to genetic. We have current imaging modalities for mammography is many improvement from screen-frame mammography to digital mammography, 3D and tomosynthesis, and then ultrasound, CT, MRI, and positron emission tomography. In Myanmar, according to WHO 2020, breast cancer death in Myanmar is 3,192 patients. Percentage of total death is 0.89%, 11.49 rate, 147 in Warren. Different types of mammography. Mammography is a dedicated radiographic technique for imaging the breast. The resultant images are known as mammogram. Two types of mammography, screening and diagnostic. Screening mammography. We have to do screening regularly. Actually, in Myanmar, very rare screening for mammography, including me. Screening is looking for signs of disease, such as breast cancer, actually before a person has symptoms. Goal of screening is to detect cancer at early stages. Sometimes screening does find cancer that is very small or very slow growing. It is very lucky for ladies. Diagnostic mammography is according to abnormal finding in screening or any symptoms for breast cancer, any pelvic lump or nipple discharge, any abnormal finding ourselves or our data. Actually, improving modalities is day by day, decade by decade. The detection of breast cancer by mammography has now been utilized the traditional and recommended route. We are already use screen-frame mammography. We still use screen-frame mammography today. Considering the rapid growth in digitalization and computer development, imaging for breast cancer has improved massively. Conventional to digital mammography, 2D, 3D, tomosynthesis, and then ultrasound, CT, MRI, and PET. There are notable development in the field of mammography, ultrasound, MRI, nuclear medicine that holds the potential to be the standard in the future for breast cancer imaging. We are now using gold standard for histopathology. Imaging modality combined with histopathology is the best imaging to breast for patients. According to National Institute for Health and Care Excellence Guideline, radiological assessment more followed by co-bouncing, referred within 2 weeks or referred per week. Women under 40, ultrasound is the imaging modality of choice. I would like to push all ladies over the world, especially sometimes men including, to do regular scan, screening, especially post-operative. For early detection for breast cancer, screens for cancer changes and reduction in mortality. This is important for regular scan. I would like to show comparison about imaging modalities within mammography. Very improvement in imaging modalities and technique. Actually, basically, mammography is the screening mammogram is performed on a woman, no clinical symptom or complaint to detect early stage of clinically occurred breast cancer. Basic view, CC and MLO, craniocordial and mediolateral oblique of each breast are obtained for routine evaluation. Limitations vary by type of mammogram. Last one is flash mammography. We use X-ray. X-ray transmitted through the breast tissue to create an image that is processed and displayed as a grayscale image directly on a film. Adequate breast compression is required because we can mimic scar and abnormal and normal tissue. Women with larger breasts may require more than 2 views of each breast to ensure imaging of all breast tissue. We have to evaluate on one plane all breast tissue, especially axillary tissue, to check lymph node enhancement. Then, average radiation dose is 4.7 milligram. Limited depend on sensitivity in women with radiographically dense breasts. Sometimes we use cooperate with flash mammography and ultrasound. Subject to artifact from processing and storage is one of the limitations in ability to manipulate the image following procedure because flash mammography is analog image. And then improve in digital mammography. Digital detectors convert the X-ray photon to an electronic signal that is changed to a digital image. We can process and display and store easily or send electronically. Software can be used to help interpret digital image by radiologists on monitor. We can manipulate because this is digital images. Maybe more effective than flame in women younger than 50. Women with heterogeneously or extremely dense breast tissue or pre or perimenopausal women. Radiation dose is lower than flash mammography, 3.7 milligram. But a little limitation, less spatial resolution compared with flash mammography, but more expensive than flash mammography. According to digital mammography, we improve in thin slice section. This is called tomosynthesis of breast. A modification of digital mammography that requires images of stationary, compressed breast at multiple angles during a short scan. Multiple angles is very important because we have to find very minute lesions in soft tissue. Normal and abnormal all are soft tissue. That's why we have to take our mammogram. Individual images are constructed to generate a series of thin sections of images that can be displayed individually or in a loop. Used in combination with standard digital mammography for screening, we can use nowadays digital mammography for screening and tomosynthesis together. Average radiation dose 1 to 2 times than digital mammography. When performed in the screening setting, the patient is exposed to approximately twice the usual radiation dose. This is the limitation, which can be even greater if the patient has dense or thick breasts. We have to emphasize the woman who has dense breasts. And then ultrasound. Ultrasound is very rare use, and then we have to cooperate with flash mammography or digital mammography together with ultrasound is the best imaging modalities for mammography. Ultrasound use sound wave to create images of breast using non-invasive, no radiation hazard. This is one benefit. Images obtained by radiologists or technologists and are operator dependent. But in Myanmar, only radiologists can do ultrasound. Whole breast ultrasound recently approved by FDA for screening of patients with dense breasts. Another screening tool is ultrasound. We can use ultrasound for screening, but not alone for ultrasound. Not an appropriate initial screening modality for breast cancer, but has been approved for screening in women with increased breast density. Actually not currently indicated for routine screening. Incorporate with digital mammography or digital tomosynthesis or French screen mammography together with ultrasound is better. Ultrasound alone is not a good breast cancer screening tool, has many false positive and false negative results. No uniform standards for performance. Several states have now implemented standard reporting on breast density, which includes the recommendation for ultrasound for dense breasts. But a little limitations. Variable image quality depend on the skill and experience of the examiner, according to radiologists. Depend on skill and experience of the radiologist. This is very, very important. Highly operator dependent, and there can be significant intra and inter-observer variability. Limited ability to detect ductal carcinoma. The last one is MRI with and without contrast. My opinion is imaging breast MRI with contrast is the best. Magnetic fields are used to create an image of the breast. Intravenous contrast agent given for the procedure. Not indicated for screening in average risk population. Diagnostic modality in specific subpopulation. No radiation hazard, but we have to follow MR safety and MR precaution. Not an appropriate initial screening modality for breast cancer, but we have to emphasize women at elevated risk, strongly family history of breast cancer or several genetic syndrome. This is very important to consider about the patient. I would like to present statistics demonstrate sensitivity and specificity of common modalities depicting breast cancer. MRI shows excellent sensitivity and specificity. I studied some paper, and then I will present here 2 papers only. We have to study other papers to perform better quality for breast imaging. This is other show modality, sensitivity, and specificity. And then MRI is excellent sensitivity and specificity. I would like to explain about CSM. This is contrast enhanced spectral mammography. Dual energy digital mammography is used. We have to inject contrast media 1.5 ml per kg and 3 ml per second according to body weight and rate. After injection 2 minutes, we can scan breast. We have to compare pre and post contrast images. This is CSM is very, very good imaging modalities for mammography. I have a question. What should women with breast implants do about screening mammograms? Actually, women with breast implants should continue to have mammogram because implant may also some breast tissue. Implants can hide some breast tissue, making it more difficult for radiologists to detect an abnormality on the mammogram. This is important to let the mammography facility know about breast implants when scheduling a mammogram. The technologists and radiologists must be experienced in performing mammography on women who have breast implants. If the technologist performing the procedure is aware that a woman has breast implants, steps can be taken to make sure that as much breast tissue as possible can be seen on the mammogram. This is very important because the implant is in the breast. We have to make sure that as much breast tissue as possible can be seen on the mammogram for radiologists. This is a special technique called implant displacement views may be used. We have to take our implant to one compression. Okay, I would like to present this study. This is the study. Diagnostic accuracy of contrast enhanced digital mammography in breast cancer detection in comparison to tomosynthesis, synthetic 2D mammography and tomosynthesis combined with ultrasound in women with dense breasts. So we have to study imaging modalities about imaging breasts. This paper objective is to assess the diagnostic efficacy of contrast-enhanced digital mammography for breast cancer detection and compare with 2D mammography, digital breast tomosynthesis alone, and digital breast tomosynthesis with ultrasound combination. in females with dense breast with histopathology as the gold standard. So we have to study imaging modality for digital mammography, digital tomosynthesis, and ultrasound. It was a prospective study by consecutive females presenting to symptomatic breast clinic between April 2019 and June 2020 were evaluated in digital breast tomosynthesis. Females who were found to have heterogeneously dense or extremely dense breast composition detected on 2D digital mammography, further evaluated with high-resolution breast ultrasound and contrast-enhanced digital mammography before the core biopsy or surgical excision were included in this study. 2D digital mammography was derived from post-processing reconstruction of digital breast tomosynthesis datasets. We have to take care about that. This study includes 166 breast lesion, 130 patients, mean of 45 plus or minus 12, age range is 24 to 72 years old. There were 87 malignant and 79 benign lesions. Sensitivity of contrast-enhanced digital mammography was higher than 2D digital mammography, digital tomosynthesis alone, and digital tomosynthesis and ultrasound combination. Specificities of contrast-enhanced digital mammography was higher than 2D digital mammography, comparable to digital tomosynthesis alone and digital tomosynthesis with ultrasound. We can find that contrast-enhanced digital mammography is better. Female with a pregnancy, renal insufficiency, or prior allergic reaction to alternative contrast agent were excluded from the study because we have to use contrast agent. Image interpretation was done by 2 experienced breast radiologists because the radiologists were well trained in breast imaging, and both are blinded to histological diagnosis. This study conclusion: contrast-enhanced digital mammography is an accurate diagnostic technique for cancer detection in dense breasts. Contrast-enhanced digital mammography alone is significantly higher number of breast cancer detection than 2D digital mammography, digital tomosynthesis alone, and digital tomosynthesis with ultrasound in females with dense breasts. This is very important for us. We have to check which technique is the best for breast imaging. Advanced in knowledge, contrast-enhanced digital mammography is a promotion novel technology with higher sensitivity and negative predictive value for breast cancer in females with dense breasts, in comparison to digital tomosynthesis alone or digital tomosynthesis with ultrasound. Second study is positron emission tomography, MRI, for local tumor staging in patients with primary breast cancer. Comparison with positron emission tomography, CT, and MRI. This study aims to assess the diagnostic performance of integrated PET MRI of the breast for lesion detection and local tumor staging of patients with primary breast cancer in comparison to PET CT and MRI. 49 patients with biopsy-proven invasive breast cancer were prospectively enrolled in the study. All patients underwent PET CT and subsequently contrast-enhanced PET MRI for the breast after written informed consent. This is a regular imaging technologist duty before each examination. 2 radiologists independently evaluated the corresponding datasets, PET CT, PET MRI, and MRI. 3 imaging modalities were instructed to identify primary tumor lesions as well as multifocal, multicentric, and bilateral disease. Furthermore, the occurrence of lymph node metastasis was assessed. The stage of each patient was determined. Histopathological verification of the local tumor extent and axillary lymph node status was available for 30 of 49 and 48 of 49 patients respectively. For the remaining patients, consensus categorization was performed for the determination of the stage and node status, taking into account the results of clinical staging, PET CT, and PET MRI examination. Statistical analysis was performed to test for differences in diagnostic performance between the different imaging procedures. We have to compare imaging modalities for breast imaging. PET MRI and MRI correctly identified 47 of the 49 patients with primary breast cancer, whereas PET CT annual detection of 46 of 49 breast cancer patients and mixed asynchronous carcinoma in the contralateral breast in one patient. So PET CT missed one patient. In a lesion by lesion analysis, no significant differences could be obtained between the 3 imaging procedures for the identification of primary breast cancer lesions. But MRI and MRI alone for a correct identification of multifocal multicentric disease in 3 additional patients if compared with PET CT. Differences between the imaging modalities were not statistically significant. This paper conclusion, integrated PET MRI does not provide diagnostic advantages for local tumor staging of breast cancer patients in comparison to MRI alone. Positron emission tomography MRI and MRI annual and improved determination of the local tumor extent in comparison to PET CT, whereas all 3 imaging modalities offer a comparable diagnostic performance for the identification of axillary disease. Summary is my presentation summary. The application of mixed imaging techniques provide crucial information which can be useful for staging and therapy planning for breast. In recent years, medical imaging became a crucial part of breast care and has been utilized in all phases of cancer management, from detection to post-treatment follow-up. Thank you very much. Thank you for your attention.
Thank you so much, Ms. Yanu, for your wonderful and informative presentation. Thank you. Proceeding with the program, please welcome our last speaker, Ms. Thandar, Senior Imaging Technologist at Parami Hospital, with the topic, Pediatric Primary Liver Tumor, Hemoblastoma.
Good morning, everyone, and welcome to my presentation. Good morning, everyone, and welcome to my presentation. First of all, let me thank you all for coming here today. It's an honor to have the opportunity to address such a distinguished audience. My name is Thandar. I am Senior Imaging Technologist from Parami General Hospital. My topic today is Pediatric Primary Liver Tumor, Hemoblastoma. Outlines of my presentation are anatomies of the liver, liver tumors, types of liver tumors, Hemoblastoma, signs and symptoms, causes, pretest and case report, diagnosis, chemotherapy and case report, palliative chemotherapy and case report, and prognosis. So let me start my presentation with anatomies of the liver. The liver lies in the right hypochondrians of the abdomen. In liver, there are two major lobes, right lobe and left lobe. Two accessory lobes are caudate lobe and quadrate lobe. Ligaments of the liver are right triangular ligament, falciform ligament, left triangular ligament, round ligament, coronary ligament, and ligamentum venosum. Liver tumors. Liver tumors or hepatic tumors are abnormal growth of liver cells on or in the liver. Several distinct types of tumors can develop in the liver because the liver is made up of various cell types. Liver tumors can be classified as benign non-cancerous or malignant cancerous group. Types of liver tumors in children. There are two types of liver tumors, benign tumors and malignant tumors. Benign tumor can happen at different ages. Some baby might be born with one, others form earlier in life, but might not be found until later. Types of benign liver tumors include hemangioma, mesenchymal hematoma, and adenoma. Malignant tumors can happen less often than benign tumors. The most common types of liver cancer are hepatocellular carcinoma (HCC), hepatoblastoma, fibrolamellar hepatocellular carcinoma, and differentiated embryonic sarcomas of the liver. Hepatoblastoma. Hepatoblastoma is a rare tumor and abnormal tissue growth that originates in cells in the liver. It is the most common cancerous malignant liver tumor in early childhood. Most hepatoblastoma tumors begin in the right lobe of the liver. Hepatoblastoma primarily affects children from infancy to about 5 years of age. Most cases appear during the first 18 months of life. Signs and symptoms depend on size of the tumor. They tend to be different in each child. These include a large mass in the abdomen, swollen abdomen, weight loss, decreased appetite, vomiting, jaundice, which is yellowing of eyes and skin, itchy skin, anemia, and back pain. Causes. The cause of many malignant liver tumors isn't known, but some health conditions make it more likely for a child to develop one. Hepatoblastoma is more likely to happen in boys and in kids with Bergwijn-Wiedemann syndrome, a disorder that can cause too much growth in the body, including the organs. Familial adenomatous polyposis, a condition that causes polyps, some growth in the large intestine. A very low birth weight or being born early. Pretreatment extent of the disease-scoring system pretest. The pretreatment extent of disease-scoring system pretest involves classifications of liver tumors by dividing the liver on imaging into 4 sectors and determining how many sectors are involved by tumor. In pretest 1, there is 1 section involved, 3 adjoining sections are tumor-free. In pretest 2, there may be 2 conditions. 2 sections involved, 2 adjoining sections are tumor-free, or 1 section involved, 2 adjoining sections are tumor-free. In pretest 3, there may be also 2 conditions. 3 sections involved, 1 section is tumor-free, or 2 sections involved, 2 non-adjoining sections are tumor-free. In pretest 4, all 4 sections involved. I divided my case report into 2 sections, pre-chemotherapy and post-chemotherapy. In case report of pre-chemotherapy, patient 1, an 11-month-old baby boy with a history of mass in left side of abdomen for 1 month. After the CT scan of this patient, there is hepatoblastoma in segment 2 and 3 of left lobe of liver, pretest 1. In patient 2, a 1-year-old baby boy with a history of mass in RAC for 1 month. After the CT scan, the impression is hepatoblastoma in segment 6 of right lobe of liver, pretest 1. Diagnosis. In diagnostic imaging, ultrasound, CT, and MRI are included. Blood tests are for checking of blood clotting problems, liver and kidney function, tumor markers, gene problems, and more. In blood tests, alpha-fetoprotein is a specific indicator for hepatoblastoma and important for disease follow-up. It increases in more than 90% of patients. It should be considered when analyzing the clinical significance of AFP. The average AFP of the newborn is about 62.7 nanogram per ml, and it reaches the peak in the first month after birth. The average AFP is about 1,200 nanogram per ml. After 3 months, it decreases to 3.15 nanogram per ml, the level of normal adult. In addition, the LDH, cholesterol, and alkaline phosphatase are also increased. The liver function is normal at early stage, middle, and late stage. Tumor biopsy, examples of the tumor is taken and checked with a microscope for cancer cells. A biopsy is needed to diagnose hepatoblastoma. The biopsy may be done with a needle or with surgery. In bone scan, this imaging test uses a special radioactive material that is injected into a vein. The substance collects in areas of the disease bone and is sensed by special cameras that pick up radioactivity. Chemotherapy. Most children diagnosed with hepatoblastoma require treatment with chemotherapy. Chemotherapy works by interfering with the cancer cell's ability to grow or reproduce. Each child is assigned a comprehensive team of providers, which includes a primary attending physician, a primary fellow or trainee, a nurse practitioner, a primary nurse, and a psychological provider. Case report of post-chemotherapy. I have only post-chemotherapy patient data. So I submit that in. So I submit these 2 patients in post-chemotherapy session. Patient 1, a 2-year-old baby girl with a case of hepatoblastoma and ongoing chemotherapy, 7 cycles is completed. After the CT scan, there is hepatoblastoma, right loss of liver with improvement, residual mass lesion with PV thrombus, and cavernous transformations of portal vein. In patient 2, a 3-year-old baby girl with a case of hepatoblastoma and ongoing chemotherapy, 8 cycles is completed. There are multiple extrahepatic arterial protections and nodule at the segment 7 of right lobe of liver. Palliative chemotherapy. Chemotherapy is typically recommended in 2 situations. The first one is to treat cancer and keep it from coming back. The second is to help shrink the cancer, reduce symptoms, improve qualities of life, and possibly prolong life. When chemotherapy is used in the second situation, it is called palliative chemotherapy. Palliative chemotherapy is typically used when the cancer has spread and chemotherapy is not being used to cure the cancer. The main goal of palliative treatment is to improve qualities of life. Case report, a 4-year-old baby boy with a known case of hepatoblastoma and completed chemotherapy. Now he is ongoing palliative chemotherapy. There is hepatoblastoma with internal improvement, residual tumor at the segment 7. Prognosis. Prognosis greatly depends on the extent of the disease, the size and locations of the tumor, presence or absence of metastasis, the tumor's response to therapy, the age and overall health of your child tolerance of specific medication, procedure or therapies, new developments in treatment. As with any cancer, prognosis and long-term survival can vary greatly from child to child. Prompt medical attention and aggressive therapy are important for the best prognosis. Continuous follow-up care is essential for a child diagnosed with hepatoblastoma. New methods are continually being discovered to improve treatment and to decrease side effects. These are the references of my whole presentation, and I collect imaging data of patients from our hospital. As a final, thank you, special thanks to 14-star company and special thanks to Nilachu and Parami imaging team. I am so glad to participate as a part of this great event, and thank you all for your time.
Thank you so much, Ms. Thandar, for your interesting presentation. Heartfelt thanks to all of our speakers for your wonderful and amazing presentations. Well, according to the agenda, Yes, may I warmly invite Dr. Goi, Head of Marketing Department at 14 Stars Northright Company, for her solutions for medical imaging in Myanmar.
Hello, everyone. Mingalaba. It's my pleasure to see you again in 17th Asia Continuous Professional Development. A year ago, we were together in that 10th event, and this is my second time of having the great time with all of you. This year, I would like to share the medical imaging solutions which are updated in our country. The medical imaging in diagnostics and prognostics are important not only for the prevention, but also for the curation in healthcare service. It would be better if the procedure and operations aren't demanding effort of healthcare professionals in their export industry. Not only the effective and smooth user interface operation, but also the safety of healthcare service surrounding are needed on ground. That's why today, medical research and development centers are ready to upgrade their healthcare service operations. Now, I will present what upgraded solutions are available in Myanmar. Let's start with digital tomosynthesis in robotic X-ray system. Here, what we saw is by using the DSRS software application, underlying pathology can be seen without much radiation exposure and examination time. This can be applicable as interventional medical examination between 3D and 2D recorded image. Digital tomosynthesis is an X-ray imaging technique that can be used to screen out even for the early signs of underlying pathology. Mostly used as a diagnosis tool. In the next slide, there will be the fluoroscopic X-ray system, which can be applied under the therapeutic surgical operations. Spinal 3G mobile surgical fluoroscopic X-ray system can support the live image surgery navigation system. Live images will be recorded with CCD camera and presented onto medical grade monitor. Even on the design, the system was optimized to fit with the surgery room environment. There is purpose for convenient user interface and safety. Now we can see how user-oriented process of the 3G mobile surgical fluoroscopic X-ray system. shown here is the stress-free operation in the surgical operation. And another procedure for the stress-free operation in routine checkup and pathology examination of the whole body is the Rose's X-twin imaging system. In this situation, investigation of the patient for the whole body examination and routine medical checkup need time to save for reducing the waiting time of even temple people, we have to use the smart operation system. Rose X-twin is one of the solutions which can run under pictogram guided operation. As a result, the time is saved and ready for the next patient. Another favorable function to help the technologists and technicians is automated motorized tracking function, which was expressed as move the system, not the patient. In all positioning stage, even like the sky view position, Rose's X-twin optimized the workflow for easy operation. We can show in the video. To be compatible to work with the X-ray imaging system, digital radiology are essential not only for the individual human but also for the veterinary and industrial surgeon. Before, Vision digitals are designed of 3 sizes. Now, the Prudent series is the upgraded version with more free mobility and durability flat panel digital. In emergency or outdoor radiography, no need to worry about that. Prudent version is designed for easy gripping and water resistant, dust resistant. Every body parts can be comfortably investigated because of the weight bearing for whole surface of 500 kg and point bearing weight for the 180 kg. Even with the small X-ray source, Prudent digitals work well due to the high sensitivity with double LED. Only need to choose you want to use either indoor or outdoor radiography. The imaging diagnosis will be the smooth operation with Prudent digital, like we show in the video. And another imaging solutions which are commonly used in our country are the high-frequency X-ray and portable equipment. We can save lives with better therapeutic interventions with portable X-ray in urgent cases. In the radiation, X-vision 525 works more than other high-frequency X-ray is because of its capacitor type system, which can be run or without the electricity. All the medical imaging that I mentioned before are installed and used at the divisions and states in Myanmar. When I mentioned the uses of the imaging system, then needed steps to readily used in the healthcare sector shouldn't be missed out. Voting Star Network Company can give the one-stop solution service from license registration up to the broader training and maintenance service for the convenience of user. The engineers are trained from international healthcare provider and can give the full satisfaction of service. For the standardized engineering process and delivering the healthcare product, we've got an ISO certificate recognition. With the practice, Voting Star Network Company has 18 years of experience in installation of over 300 units of medical imaging systems and upgraded solutions in Myanmar. And our business group has strong connections between engineering service, hospital management at Nway City, and medical gate solution. So what can be expected from Voting Star Network as a customer is we can give commitment in service and maintenance solution. If any inquiry, come and visit to our office at Yangon and Mandalay. Thank you so much for your time today. This is one of the pleasant memories. Hope to see you all in next year of Asia CPD Myanmar host. Thank you all the panelists and presidents of Asia CPD and the attendees and Myanmar local associations, online and offline event attendees.
Thank you so much, Ms. Kawi, for your very informative solutions about that. And also thank you for your big effort to sponsor our 70th online CPD platform. Thank you. Proceeding with the program, appreciation speech will be given by Mr. Aung, Managing Director of 14 Stars Network Company. I respectfully invite Mr. Aung to deliver the speech of appreciation.
Good afternoon, everyone. At first, I would like to introduce myself. My name is Aung, Managing Director for 14 Stars Network Company Limited. The purpose of our company is to deliver the best healthcare solution and engineering service to all medical facilities in our country. The development of imaging technology in diagnosis is very important to give the right treatment to the patients in a more effective and comfortable way. That is why we are trying to distribute more supportive imaging and upgraded solution in Myanmar year by year. And I hope the purpose of celebrating the Asia Continuous Professional Development is to continue the development of the profession in medical imaging technology by sharing the knowledge to medical imaging professionals all over the world. According to this valuable purpose of Asia CPD organization, I really appreciate everyone here for supporting the continuity of profession development by sharing about medical imaging technology as a part of organizer team. Moreover, we are also glad to share the professional knowledge about imaging technology to international healthcare industry. And I also want to give my gratitude to all the academic speakers and panelists of the 70th Asia CPD. Eventually, I would like to say thank you to the Asia CPD Society for giving us the chance to take part by contributing sponsorship for this event. In fortune favors, see you all next year. Wish you all the best.
Thank you so much, Mr. Aung, for your appreciation, and also thank you for sponsoring to become such a successful CPD online platform. Thank you. Well, we are almost at the end of the closing ceremony, but before we close, may I respectfully invite Mrs. Xin Then, Imaging Manager at OSC Hospital, and also a General Secretary of MSMRT Association, to deliver the speech of acknowledgement.
On site ပေါ့နော်ကျင်းပတဲ့ဒီခန္ဓာလေးကိုအချိန်ပေးပြီးတော့အခက်အခဲမျိုးကြားရနေပြီးတော့လာရောက်ပြီးတော့တက်ရောက်ပြီးတဲ့အားပေးပြီးတဲ့တက်ရောက်ပြီးတဲ့လူတွေအားလုံးကိုပထမဆုံးကျေးဇူးတင်ပါတယ်ကိုဗမာလိုပဲပထမဆုံးနှုတ်ခွန်းဆက်တာပါတယ် I'm very excited. Good morning again. First of all, I want to say that I believe all of us missing and remembering our leaders, Mr. Kemaude.
He built up MSMRT and introduced us with the Indonesian Association to develop growth technology and friendship each other. Now, okay. Good afternoon, ladies and gentlemen. Now, the 17th Asia CPD has been successfully held, and we believe it will be effective for everyone. First of all, we would like to pay tribute to the IT teams of 14th Standard Company Limited and responsible persons who provide technical assistance to make this event. Besides, I would like to express my sincere thanks to all presidents, panelists, and all technologists from international associations and watching live streams, Facebook, YouTube, and online sections. The other people who need to be thanked are the speakers from various hospitals who read precious presentations in this webinar. Without these academic papers, we would not be able to exchange technical knowledge like this. Please kindly let us record and honor the hard work each technologist. Furthermore, I would like to thank all the members or representative MSMRT and those who could not join but providing the strengths. Special thanks of Mr. Tribalot, Ms. Pichi Lunas, Mr. Frenacott, who helped and instruct me in a timely manner. We are willing to work together with them in future of more effective progress. Thanks everyone who have from all necessary side. Let's kindly announce this event. May we meet later and have a nice day ahead, everyone. Thank you so much for your participants and cooperation. Thank you.
Thank you so much, Ms. Sinyadan, for your acknowledgement. Ladies and gentlemen, just before we close the program, let's take some time for questions and answers section.
Sorry.
Yeah, I invite Ms. Pichi Lunar from the Philippines to continue for the closing the ceremony. Thank you.
Yes, thank you, our program moderator, Ms. Mazin Soe. And thank you very much. Yes, again, thank you very much, program moderator, Ms. Mazin Soe. And thank you very much, presidents and our panelists. The Myanmar Society of Medical Radiation Technologists has provided us with 4 great speakers who have just shared to us very interesting discussions. But in the interest of time, we have to cut from here to give way for the closing session. So again, thank you so much to our distinguished speakers. We have learned so much from your interesting and very important discussions. Finally, we are all excited to know about the next exciting online CPD Asia schedule and to address an invitation and to tell us more about the exciting event. Let us all welcome the President of Hong Kong Radiographers Association, HKRA, President Wan Shu Boon Nelson.
Hi, everyone. I would like to, it's my great pleasure to present to you the next CPD will be held by Hong Kong Radiographers Association on the 20th of August, on the Saturday, at around 2:00 p.m. And our topic will be on the patient safety. We have invited some local speakers from the hospitals, from the medical physics, and also radiation therapists. And we have some vendors, specialists, to talk about the contrast safety, radiation safety, and also those issues about medical imaging and also radiation therapies. So the details will be released very soon. So please join us and register through the Zoom. Thank you.
Yes, there you have it. Speaking for HKRA President Shun Buen Nelson is Mr. Philip Chu. Surely we'll be supporting you, the HKRA, for your hosting of the next big exciting event. So everyone, please see updates and relative posts regarding the announcement of the 18th CPD Asia, which is going to be out soon. So please keep updated always. So in closing, again, our congratulations to Myanmar Society of Medical Radiation Technologists, all its officers, Ma'am Secretary General Yin Yin Tan, and the organizing committee of the 17th CPD Asia. And again, we always are thankfung for the support of our sponsor, VT Healthcare Vietnam. We are grateful to our fourth grade speakers, Mrs. Yin Mon Ye, Aung, Ms. Yin Nway O, Mrs. Thandar Aung, and special thanks to Dr. Gonyi, the head of marketing of 14th Star Network Company, and Mr. Aung Kiao. Most of all, we are sincerely grateful to all the member societies presidents, to our very hardworking CPD Asia IT team, and to all the registered participants who have made this online CPD Asia program a success. So see you all again in the next Asia CPD. Again, I am Peachy Lun, and I say thank you everyone and have a great day.
Goodbye. Congratulations, Myanmar Society. Congratulations.
Congratulations, MSMRT.
Yeah, congratulations to the Myanmar team for making a wonderful program today. It's nearly more than 2 hours. Yeah, very good sharing of the information on the different topics. Really interesting one. Thank you all for making this a good event. Thank you all the participants and all the partner associations to make this event. We are looking for that next month safety issues by conducted by Hong Kong team. Thank you all. Namaste.
Thank you so much.
Excuse me, I want to have a question about India. When is the Indian Society's Asia CPD Day?
We are planning for September, sir.
September.
Yeah, September.
Yes.
Soon we will give you details.
Okay,
in
so it's
consultation with the team.
So it's the same month of the Macau, right?
Yes.
Macau,
Okay, I think we discuss later with Fernando.
Yes.
I will discuss with you.
Okay,
Yeah.
okay.
Yeah, India is September.
Okay.
Yeah, I will discuss with you later.
I'm so happy to the India to join us. It's the first. Yeah.
Thank you all for making us to be a part of the team. Thank you.
Yes, we need more support for more societies for this platform. Thank you so much.
Definitely, sir. We are with you.
Thank you.
Yeah.
Thank
Congratulations, Indonesia. Congratulations, India. Congratulations, India.
Thank you, sir.
Okay, thank you. See you next time. Bye-bye.
Bye-bye. See you.
Bye. Goodbye to
Bye-bye.
everybody. Meet again next month.
Yes,
See you.
in Hong Kong. Yes.
Take care.
To Hong Kong, Nelson.
Yeah.
Yes.
Thank you and congratulations, MSMRT. Hi, Madam Yin Yin O.
Ali, thank you. See you.
See you all soon in
Thank
Yangon
you.
or in Myanmar.
Yes, sure.
Recording stopped.
Selamat siang, Deputu Hanthar. Ya, terima kasih Mas Irfan atas support dan atas keikutsertaannya.
Ya, kami coba sambungkan lagi ke Myanmar. Oke, post testnya saya kirim ke kolom chat. Mohon ditunggu.
I wish that I can